Part A. Extract 1. Questions 1 to 12. You hear a general practitioner talking to a patient called Mihira. You now have 30 seconds to look at the notes.
Good morning, Mihira. What brings you in today?
Morning, doctor. Well, it's not exactly a new problem, but it's escalating, I suppose. It's this persistent ache, you see. It started subtly, maybe a few months back, just a sort of dull throb at the base of my skull, almost like a tension headache that never quite blossoms, if that makes sense. But now it's radiating right down my neck and even into my shoulders, especially the left one. It feels almost gnawing sometimes. I wake up feeling like I've slept on a bed of bricks, and by midday, it's practically shouting at me. And there's this stiffness, a real unyielding stiffness.
I see. Mihira, can you describe the pain's quality in more detail? Is it sharp, dull, burning, or tingling?
Oh, it's definitely not sharp, no. But there are moments, especially when I turn my head quickly, where it feels like a sudden, almost electric jolt, but that's fleeting. And the stiffness, that's the worst, truly. It restricts my range of motion quite significantly. Trying to look over my shoulder when I'm driving is becoming a real challenge. You know? I have to move my whole body. And lifting things, even like groceries, sends a peculiar sort of spasm down my arm, though not all the way to my fingers, thankfully.
And you mentioned this has been ongoing for a few months. Have you noticed any exacerbating or alleviating factors, Mihira?
Well, yes. It's much worse after I've been sitting for long periods, particularly at my desk. I work as a graphic designer, so I'm hunched over a computer for hours on end, you see. And sleeping. I've tried different pillows, feather, memory foam, even one of those contoured orthopedic ones, but it doesn't seem to make a significant difference. Oddly, a warm shower can provide some temporary relief, and if I do some gentle stretching, like tilting my head from side to side very slowly, it eases the tension for a short while. I've been taking paracetamol, sometimes even ibuprofen, but they barely touch the surface now.
Okay. And regarding your general lifestyle, Mihira, are you active? Do you engage in any regular exercise?
Not as much as I should, I confess. My job is quite sedentary. I try to walk my dog for about 20 minutes in the evenings.
Right. Given your detailed description, Mihira, it strongly suggests a case of cervical myofascial pain syndrome, likely exacerbated by postural stressors. We need to address the underlying muscle tension and improve your ergonomics.
So it's not a slipped disc or anything serious then. I was starting to worry.
While a thorough examination is still necessary to rule out any red flags, your symptoms are highly indicative of a muscular origin. My initial recommendation would be a multi-pronged approach. Firstly, I'd like you to start with physiotherapy. They can guide you through specific stretching and strengthening exercises to improve your cervical posture and muscle imbalances. I'll provide you with a referral. Secondly, I'd suggest a course of a nonsteroidal anti-inflammatory drug, say naproxen 500 milligrams twice daily for 10 days, to reduce the inflammation and alleviate the pain.
Okay, what about my work setup? Do I need to get a special chair or something?
Absolutely. I'd advise ensuring your computer monitor is at eye level, your keyboard and mouse are easily accessible without strain, and you take frequent breaks, every 30 to 45 minutes, even if it's just to stand up, stretch, and walk around for a minute or two. Conscious effort to maintain a neutral spine and avoid prolonged neck flexion, especially when using your phone, will be key. I also recommend applying a warm compress to the affected area for 15 to 20 minutes, a couple of times a day, particularly before the physiotherapy exercises. I'd like to schedule a follow-up appointment for you in 3 weeks.
Okay. Thank you, doctor.
Extract 2. Questions 13 to 24. You hear a community health nurse talking to a patient called Mihira. You now have 30 seconds to look at the notes.
Good morning, Mihira. What can I help you with today? I see you've booked in for a general consultation.
Good morning, Samuel. Oh, it's primarily the right hip, right in the groin area, almost like a persistent toothache, but in my joint, if that makes any sense. It started subtly, probably 6-7 months ago. Just a little niggle, a stiffness in the mornings, particularly after I'd been sitting for a while, like after my commute. And it radiates down the front of my thigh, sometimes even to my knee. It's not a sharp, stabbing pain all the time, more of a dull, unrelenting throb, but then I get these sudden, acute jolts if I move suddenly or try to pivot.
I understand, Mihira. Can you describe how it's affecting your daily life? What are the limitations you're experiencing?
Oh, the limitations. They're immense. I'm a year 5 teacher, so I'm on my feet all day. Standing for long periods in front of the whiteboard, circulating the classroom, bending down to help children, it's all become excruciating. Getting up from a chair after marking papers feels like I'm an ancient relic. And forget about the stairs at school. I cling to the banister like my life depends on it, taking them one step at a time. Simple things like getting dressed, putting on socks, or even reaching for something in the back seat of my car, the flexibility is just gone.
That sounds incredibly debilitating, Mihira. Have you tried any remedies or sought any treatment for this previously?
Well, initially, I thought it was just muscle strain and tried topical anti-inflammatory creams like Voltaren gel. And I take over-the-counter paracetamol, sometimes ibuprofen, especially before a long day at school, but never really fixed anything. I even tried a couple of sessions with a masseuse, thinking it was just tight muscles in my glutes, but that provided only very transient relief. It certainly didn't address the underlying issue.
Okay, thank you for that comprehensive overview, Mihira. From what you've described, it sounds highly suggestive of coxarthrosis. To get a clearer picture, I'd like to perform some examinations. My primary recommendations would be a referral for a radiograph of your hip to confirm the diagnosis and assess the extent of joint degeneration. Following that, a comprehensive physiotherapy program is paramount. A physiotherapist can teach you specific exercises to strengthen the muscles around the hip, improve flexibility, and reduce pain. This often involves aquatic therapy too, which can be very beneficial as it reduces weight-bearing stress.
Okay. And medication?
For pain management, I'll liaise with the GP for a prescription for a more potent analgesic, a trial of duloxetine for neuropathic pain. It's crucial to manage the pain effectively so you can participate in the exercises. We also need to discuss weight management, if applicable, as excess weight significantly increases stress on the hip joint. And consider using a walking aid, in the short term, especially for longer distances or when your pain is acute, to offload the joint.
Oh, I really don't want to use it. How long will this all take, Samuel? I just want to get back to teaching without this constant agony.
The timeline for improvement with conservative measures can vary, Mihira, but consistent effort with physiotherapy and adherence to medication are key. We'll reassess your progress regularly. I'll make sure to book you in for a follow-up here in about 4 weeks to review your X-ray results, discuss your response to the initial treatments, and see how you're coping. At that point, if conservative measures aren't yielding sufficient improvement, we can explore other options, including specialist referral to an orthopedic surgeon for further evaluation. Are there any questions you have for me at this point?
I'm really hoping this works. Thank you, Samuel.
We'll work through it together, Mihira.
Part B. In this part of the test, you'll hear 6 different extracts. You'll have time to read each question before you listen. Question 25. You hear a nurse called Mihira talking to a junior nurse. Now read the question.
All right, Liam, quick briefing on Mrs. Henderson in room 7. She's stable post-cholecystectomy, but her pain management is proving a bit dynamic. The patient-controlled analgesia isn't quite hitting the mark for her incisional discomfort, despite repeated boluses. We tried adjusting the basal rate earlier, which seemed to initially help with the general ache, but her breakthrough pain episodes are still quite frequent, especially with movement.
Right, Mrs. Henderson, PCA not fully effective. Mihira, should I reassess her pain scale again, perhaps look at her facial expressions more closely?
Precisely. Beyond the numerical score, observe her nonverbal cues. Also, she's expressing some nausea, sporadic, but it's impacting her oral intake. We've got Zofran on PRN, but let's consider if it's related to the opioid or perhaps her diet. And don't forget Mr. Peterson in room 12, his blood glucose has been fluctuating wildly. His morning insulin dosage needs a meticulous double-check today, and ensure he's adhering to his diabetic meal plan, especially after that unapproved biscuit delivery from his family yesterday. His hyperglycemia last night was certainly a consequence of that.
So, Mrs. Henderson's pain and nausea, then Mr. Peterson's fluctuating glucose and diet adherence. Got it, Mihira.
Excellent. Prioritize Mrs. Henderson's pain first, then delve into the nausea. Mr. Peterson's glucose management is critical, but perhaps less immediately acute than Mrs. Henderson's discomfort.
Question 26. You hear a GP called Mihira talking to a community nurse. Now read the question.
Good morning, David. Quick update on Mrs. Albright, the 82-year-old in flat 3B. Her wound dressing for that sacral ulcer needs meticulous attention today. The exudate level has increased slightly, and there's a faint erythema around the margins, but no purulent discharge. We're still monitoring for signs of cellulitis, but it's not overtly present yet. She's reporting consistent pain, despite the prescribed paracetamol.
Right, Mrs. Albright, sacral ulcer, increased exudate, erythema, pain. Any changes to the dressing tag, Mihira?
No, continue with the hydrocolloid for now, just ensure it's secured properly to prevent further shearing. And keep a close eye on Mr. Davies, over in Cedar Apartments. His new antihypertensive regimen is causing some transient postural dizziness, especially when he stands up too quickly. He called in yesterday feeling quite faint after getting out of bed. We suspect it's related to the dosage titration. That's why he needs a domiciliary blood pressure check within the next hour. I want to confirm his orthostatic readings.
So, Mr. Davies, postural dizziness, BP check. Is that the priority over Mrs. Albright's dressing then?
Yes, David, Mr. Davies' immediate hemodynamic stability is more pressing. While Mrs. Albright's wound management is crucial, Mr. Davies' potential for a fall due to syncope represents a more acute risk to his safety. The wound can wait an hour, a fall cannot. After that, address Mrs. Albright, and then pop in on young Leo in number 17, just to check on his cough.
Question 27. You hear a GP called Mihira talking to a surgeon. Now read the question.
Dr. Peterson, thank you for taking my call regarding Mr. Harrison, patient 45B. He presented with escalating right lower quadrant pain, initially insidious, now quite sharp, accompanied by low-grade fever and mild nausea. His inflammatory markers are elevated, CRP at 45, WCC 14.7. Clinically, there's localized guarding and rebound tenderness. We're certainly thinking appendicitis.
Understood, Dr. Mihira. Sounds concerning. Any recent travel or unusual diet? Any previous abdominal surgeries?
No significant travel. Diet's been consistent. He did have a laparoscopic cholecystectomy about 3 years ago, uncomplicated. His primary concern at the moment, beyond the pain, is a persistent, non-productive cough he developed 3 days ago, which he attributes to seasonal allergies, but it's making him quite uncomfortable. However, my immediate reason for contacting you is the suspicion of acute appendicitis, which, as you know, requires urgent surgical evaluation. The cough, while bothersome, is secondary in terms of acuity.
Right, appendicitis suspicion is paramount. And the cough? Any respiratory symptoms beyond that, Dr. Mihira?
No dyspnea, no abnormal chest sounds. Just the dry cough. So, given the abdominal findings, I've already ordered an abdominal ultrasound, but I felt it prudent to get your opinion on his surgical candidacy and the potential for immediate intervention.
Absolutely. Send him over to ER. I'll meet him there and we can review the imaging together.
Question 28. You hear a head nurse called Mihira talking to a surgical team. Now read the question.
Team, quick huddle on patient Evans, post-op day 1, right colectomy. His output from the nasogastric tube has significantly decreased overnight, which is a positive sign. However, he's complaining of persistent abdominal distension and discomfort, despite the gentle ambulation we encouraged. We've got him on a clear fluid diet, but he hasn't passed flatus yet. His pain is being managed with for opioids, but we're trying to transition him to oral analgesia today.
Right, decreased NG output, but still distended and no flatus. Any bowel sounds present? And is he tolerating sips of water, Mihira?
Bowel sounds are present, but hypoactive. He's managing small sips, but it's causing more discomfort. My main concern, and the reason I wanted to brief you specifically, is the delay in return of bowel function, which is contributing significantly to his distension and discomfort. This is preventing progress with his oral intake. We need to consider proactive measures. Also, his urine output dropped slightly this morning, and we're monitoring for signs of dehydration, though his vital signs are stable.
So, primary focus on bowel function. What about the urine output? Electrolytes look okay, Mihira?
Electrolytes were within normal limits on the last panel. The urine output is secondary to the immediate concern of his ileus. Once we address the bowel function, fluid balance should normalize. We need to encourage more ambulation and consider a prokinetic agent if no improvement in the next few hours.
Question 29. You hear a nurse called Mihira talking to a surgeon. Now read the question.
Dr. Davies, regarding Mrs. Khan and roommate, post-op day 3 appendectomy. She's complaining of persistent discomfort around the incision, despite regular analgesia. Her pain score remains a 6 out of 10. We've assessed the wound. It's clean, dry, and intact, no signs of infection. Her vital signs are stable, but she's quite distressed by the pain, particularly when attempting to mobilize.
Understood, Mihira. Is she verbalizing any other symptoms? Any nausea, or perhaps referred pain elsewhere?
She did mention some intermittent, mild shoulder tip pain this morning, which we attributed to potential diaphragmatic irritation from the surgery, but it's very transient. The primary issue remains the incisional pain. However, her reluctance to ambulate due to this discomfort is significantly impacting her pulmonary function. Her chest auscultation reveals some basal crepitations, and her oxygen saturation is dipping to 93% on air when she's recumbent for extended periods. This is a direct consequence of her immobility. We've been encouraging deep breathing exercises, but the pain is hindering her cooperation.
Right, so the pain is directly affecting her respiratory status. What about her bowel function? Any flatus or bowel movements yet, Mihira?
No flatus or bowel movement yet, though bowel sounds are present. We're still on clear fluids. But the most immediate concern is her declining respiratory mechanics. We need to ensure she can clear her secretions and maintain adequate oxygenation.
Question 30. You hear a doctor called Mihira talking to a physiotherapist. Now read the question.
Liam, thanks for coming down. I wanted to discuss Mr. Jenkins, 78, post-hip replacement, day 2. His pain management is satisfactory, and the surgical site looks good. He's cooperative, but there's significant apprehension about weight bearing. He keeps saying he feels unstable, despite us reassuring him about the implant.
Right, post-op hip, pain controlled, but apprehension about weight bearing. Dr. Mihira, is he reporting any specific discomfort with movement, or just general fear?
It's more a general fear of falling, a psychological barrier. He's very risk-averse. His muscle strength is adequate for his age, and his range of motion is progressing as expected. However, his reluctance to fully engage in mobilization is significantly impacting his discharge planning. We can't safely send him home until he demonstrates independent transfers and a stable gait, and his current hesitation is delaying that critical step. We've managed to get him to stand for short periods, but sustained effort is proving difficult.
So Dr. Mihira, the psychological aspect is paramount. What about his home environment? Is it suitable for his recovery, or are there obstacles?
His daughter assures us the home is well adapted, grab bars, no stairs. But the immediate hurdle is overcoming this confidence deficit. We need your expertise in progressive weight-bearing exercises, but more importantly, in building his self-efficacy regarding movement.
Part C. Extract 1. You hear a speech therapist, Mihira, and an interviewer. You now have 90 seconds to read questions 31 to 36.
Welcome, Mihira, a highly experienced speech and language therapist, joining us. Mihira, thank you for being here.
It's my pleasure, Alex. Thank you for the invitation.
Mihira, the public often has a somewhat generalized understanding of speech therapy. Could you elaborate on the most challenging aspect of your day-to-day practice that might surprise those outside the profession?
That's an excellent question, Alex. Many assume our work is primarily about articulation difficulties in children, which is certainly a significant part, but perhaps the most demanding aspect, often unseen, is navigating the profound emotional and psychological impact of communication disorders on adults, particularly those who've acquired conditions like aphasia after a stroke. Witnessing their frustration, the loss of identity tied to their voice or ability to express thoughts, requires not just clinical skill but immense empathy and resilience. It's not simply about teaching strategies. It's about rebuilding confidence and fostering hope in what can feel like an isolating battle. The sheer complexity of reestablishing neural pathways for speech in some cases, combined with the emotional scaffolding required, presents a unique set of demands that go beyond typical therapeutic interventions.
That paints a vivid picture. Building on that, Mihira, how has technology specifically reshaped the landscape of speech and language therapy in recent years, beyond simple telehealth?
Technology has been transformative, certainly. Beyond the obvious shift to remote consultations, which was accelerated by recent global events, we're seeing remarkable advancements in augmentative and alternative communication, or AAC devices. These range from high-tech eye gaze systems for individuals with severe motor impairments to sophisticated apps that offer personalized voice output. The integration of artificial intelligence in speech analysis software is also proving invaluable for objective assessment and tracking progress, allowing for far more nuanced and data-driven intervention plans than ever before. This doesn't replace the therapist, of course, but it empowers us with tools that enhance precision and accessibility, pushing the boundaries of what was previously achievable in fostering functional communication for our clients.
Fascinating. And with such complex and often long-term conditions, what role does interprofessional collaboration play in achieving optimal patient outcomes in your field, Mihira?
Interprofessional collaboration isn't just important, it's absolutely fundamental. A holistic approach is non-negotiable, particularly for complex cases like dysphagia management in palliative care or neurorehabilitation. We work hand in glove with neurologists, dietitians, occupational therapists, physiotherapists, and nurses. For instance, managing a patient with post-stroke dysphagia requires coordinated efforts. The neurologist guides the overall medical management. The dietitian ensures nutritional needs are met through modified diets, the OT might adapt feeding equipment, and the physiotherapist helps with postural support. Our role as speech therapists is to assess swallowing mechanics and implement strategies to ensure safe oral intake, but the success hinges on shared goals and consistent communication across the team. It's about creating a seamless support network around the patient.
It sounds like a truly integrated approach, Mihira. Looking forward, what emerging area of research or practice in speech and language therapy do you find most promising for future patient benefit?
I'm particularly excited about the burgeoning field of neuroplasticity-driven interventions. We're moving beyond traditional compensatory strategies towards therapies specifically designed to harness the brain's ability to reorganize itself. This includes intensive, high-frequency practice paradigms, often leveraging technology like transcranial direct current stimulation, TDCS, in conjunction with therapy to promote neural remapping. There's also significant promise in early intervention for neurodevelopmental disorders, utilizing predictive biomarkers to begin therapeutic support even before overt symptoms manifest. These approaches hold the potential to fundamentally alter the trajectory of many communication disorders, moving from management to genuine recovery or prevention.
That's incredibly hopeful, Mihira. Now, considering the emotional demands you mentioned earlier, what strategies do you employ to maintain your own professional well-being and prevent burnout in such an empathetic field?
It's a critical point, Alex. The emotional labor is substantial. For me, a structured approach to self-care is non-negotiable. This includes deliberate compartmentalization of my work and personal life. I make a conscious effort to switch off when I leave the clinic. Regular clinical supervision and peer support groups are invaluable for processing difficult cases and sharing strategies. Also, engaging in activities completely unrelated to my profession, like hiking or painting, provides a crucial mental reset. It's about building a robust personal resilience toolkit, acknowledging that you can't pour from an empty cup, especially when dealing with profound human vulnerability. It ensures I remain effective and present for my clients without becoming emotionally depleted.
A powerful reminder for all healthcare professionals. Mihira, thank you so much for sharing your insights today. It's been incredibly illuminating.
My pleasure, Alex.
Extract 2. Questions 37 to 42. You hear a nursing educator talking about her professional values at the Mihira Research Institute.
Good morning, everyone. It's a distinct privilege to stand before you today as a nursing educator from the esteemed Mihira Research Institute. My aim today is to demystify the multifaceted role we play in shaping the future of nursing, delving into its nuances beyond the conventional understanding. So, what exactly does a nursing educator do? While the image of a lecturer at a podium is certainly part of it, my role extends far beyond the classroom. It encompasses the meticulous design and continuous refinement of our curriculum, ensuring it remains dynamic and responsive to evolving healthcare demands. We are fundamentally tasked with bridging the critical gap between theoretical knowledge acquired in academic settings and its complex application in real-world clinical scenarios. This involves intensive clinical mentorship, guiding our students and even seasoned nurses in translating evidence-based research into practical, compassionate Mihira care. We're less about simply imparting facts and more about cultivating critical thinking, clinical reasoning, and ethical decision-making capabilities. The impact this role has on practicing nurses is profound and pervasive. By fostering a culture of perpetual inquiry and continuous professional development, we empower nurses to adapt proactively to new technologies and treatment modalities. Our direct engagement in clinical settings through preceptorship programs, for instance, directly enhances their practical competencies, refining their psychomotor skills and sharpening their diagnostic acumen. Crucially, by instilling a robust understanding of patient safety protocols and quality improvement initiatives, we contribute directly to a reduction in adverse events and a significant enhancement in overall patient outcomes under the banner of Mihira Care. It's about building a workforce that isn't just proficient, but also resilient and innovative. The importance of this role, therefore, cannot be overstated. We are the architects of a competent, adaptable nursing workforce capable of navigating the inherent complexities of modern healthcare. In an era of rapid technological advancement and shifting epidemiological landscapes, we ensure that nursing practice remains evidence-informed and patient-centered. Our efforts are pivotal in upholding the high standards of Mihira care, ensuring that quality and safety are ingrained from the foundational levels of nursing education right through to advanced practice. We are essentially future-proofing the profession, preparing nurses to lead and innovate in the face of unforeseen challenges. However, this critical role is not without its significant challenges. One of the most persistent hurdles is the sheer pace of scientific and technological innovation in healthcare, demanding constant curriculum updates to remain relevant. We also contend with the diverse learning styles and experiential backgrounds of our students and existing staff, necessitating highly adaptable pedagogical approaches. Furthermore, resource constraints, both in terms of clinical placement availability and technological infrastructure, often complicate our efforts to provide optimal experiential learning. Perhaps most subtle yet potent is the resistance to adopting new evidence-based practices among some entrenched clinical cultures, requiring delicate negotiation and persuasive education rather than mere instruction. Despite these complexities, the outcomes are incredibly rewarding. We witness a tangible improvement in patient satisfaction, a measurable decrease in hospital-acquired complications, and an observable enhancement in the clinical confidence and job satisfaction of nurses. Our graduates consistently demonstrate superior clinical judgment, contributing to a more effective and efficient healthcare system. Beyond individual growth, our research initiatives often lead to novel educational methodologies and direct improvements in patient care protocols that become hallmarks of Mihira care. These are not just theoretical achievements, but real-world impacts. Finally, assessing the performance of a nursing educator is a multifaceted process. While student pass rates and feedback surveys provide initial insights, a more comprehensive analysis involves tracking the long-term clinical performance of our graduates, assessing their engagement in continuous professional development, and evaluating their contributions to evidence-based practice within their respective clinical environments. We rigorously collect data on the impact of our educational interventions on patient safety metrics and overall care quality within our affiliated hospitals, looking at the practical changes in clinical settings. Furthermore, peer review, scholarly output, and participation in national nursing education forums are integral to understanding our broader influence on the profession and upholding the standards of Mihira care. It's about demonstrating tangible value through the proficiency of those we educate. Thank you.